Well, everyone, it's really a pleasure to welcome you today to the Indigenous Health and Wellbeing Colloquium Series. This is sponsored by the Harvard University Native American Program and by the Department of Global Health and Social Medicine at Harvard Medical School. My name is Joseph Gaughan, and I am a psychologist and interdisciplinary social scientist. I've been a professor here at Harvard University for coming up on 8 years. I'm currently the faculty director of the Harvard University Native American Program, or HUNAP as we refer to it, and I'm a mental health researcher, and really pleased to host this colloquium series in which I ask other mental health researchers who focus on Indigenous communities to join us and share their insights and their knowledge with us. Harvard University is located on the traditional and ancestral land of the Massachusetts, the original inhabitants of what is now known as Boston and Cambridge. Harvard University is also governed by its Charter of 1650, which commits our institution to, quote, the education of the English and Indian youth of this country. This colloquium goes back a little while. We had our inaugural seminar back in February of 2021, which means that we are almost at the 5-year mark here. So we've been doing it quite a while. We try to have about 4 of these a year, but of course some years I'm away on sabbatical or what have you. So anyway, today is our 13th seminar, for which I am really pleased to welcome Professor Teresa Brockie. Dr. Teresa Brockie is an associate professor at Johns Hopkins School of Nursing and an Indigenous nurse, scientist, and educator, known for her research focused on achieving health equity through community-based prevention and intervention of suicide, trauma, and adverse childhood experiences. A member of the Aanin Nation from Fort Belknap, Montana, Dr. Brockie is a public health nurse who earned her PhD at the Johns Hopkins School of Nursing. During her career thus far, Dr. Brockie has secured significant research funding, serving as principal investigator or co-investigator on 11 projects, including 2 R01s from the NIH and 2 randomized controlled trials. She's the elected president of the National Alaska Native American Indian Nurses Association and a fellow in the American Academy of Nursing. In 2023, Dr. Brockie was awarded the Betty Irene Moore Fellowship for Nurse Leaders and Innovators. And I should say it's an extra special colloquium today for me because there's really not that many Aanis in the world. And so I'm really delighted to welcome Professor Brockie, who comes from a respected family back home at Fort Belknap. And of course, I've been an admirer of yours for a long time, as I think you know, Dr. Brockie. Today, you're going to talk to us about, quote, reimagining our future, transforming social determinants of health in Native nations. Professor Brockie will speak until about the top of the hour, and then we'll move to a half hour or so of audience exchange. So please note that you can post your questions and comments in response to Professor Brockie's remarks here using the Q&A function in Zoom. That's the main way you'll write in. So look at the Q&A function and type in whatever questions or comments you might have. We'll get to them after Professor Brockie's finished. The event is being recorded and will eventually be available for viewing on our HUNAP website, as all of the prior events have been as well. So without further ado, Professor Brockie, the floor is yours. Thank you for joining us.
Ali, is this the right slide up?
Yes, it's perfect.
Okay, thank you. So good afternoon, everyone, and thank you for your attendance and your commitment to this essential work. And thank you to Dr. Joseph Gaughan for the invitation and for providing this opportunity through the Indigenous Health Seminar at Harvard University. Please note my area of expertise is in Native American youth suicide prevention and intervention. Therefore, my presentation is really from that perspective. So here we go. People's environments shape their early development and health, and power shapes those environments. Yet research shows that many Americans don't connect place, development, and health, leaving space for harmful narratives to take root.
Oh, if you press next, it'll go to the next one. Right there on that screen.
Bottom.
Yes, right there.
There has to be an easier way. Through this presentation, I will highlight the historical, social, and structural factors that shape health, particularly mental health outcomes among Native Americans, and highlight challenges, present solutions, and hopefully inspire collaborative action. Over the years of studying suicide, childhood trauma, and adverse childhood experiences, my knowledge and understanding have changed considerably about the contributing factors, rather, and the most appropriate approach to address these factors. These are the questions that guide my work and are important for us to consider. What factors are linked with suicide in high risk reservations in rural settings, all the way down to what is the best approach to address health outcomes and prevention efforts. So understanding social determinants of health. Social determinants of health are the conditions where people are born, grow, live, work, and age. And there are 5 categories that include economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Social determinants of health are shaped by the distribution of money, power, and resources. So I'm going to start by talking about Native Americans and the diversity within and the 2 definitions. First, the federal government, by way of the U.S. Census, defines American Indian or Alaska Native as persons having origins in any of the original peoples of North and South America, including Central America, and who maintains tribal affiliation or community attachment. And that includes 4 broad categories: Alaska Native, American Indian, Canadian Indian, and Latin American Indian. And so over a 10-year span, there's been a 160% increase in this racial category. From 2010 to 2020, the Alaska Native alone population grew by 10%. The American Indian alone population grew by 11%, and the Canadian Indian alone population grew by 20%. The Latin American Indian alone population grew by 344%. About 70% of this group live in urban areas. And while the U.S. Census reflects self-identified American Indian and Alaska Native populations, it is crucial to recognize that only individuals affiliated with federally recognized tribes are eligible for specific federal services, such as those provided by the Bureau of Indian Affairs and the Indian Health Service. This eligibility encompasses approximately 2 million American Indian and Alaska Natives across the 575 federally recognized tribes. Notably, around 70% of this group resides on or near their home reservations, where the interplay of social determinants of health significantly impacts their well-being and access to critical resources. Therefore, in this presentation, I will represent both the challenges and the opportunities we aim to address in our work to enhance health equity within Native nations. The colonization of the Americas had profound and devastating effects on Indigenous peoples, cultures, and societies. In what is now the United States, an estimated 95% of the population were eliminated. Evidence also shows that the number of Indigenous women of reproductive age was cut in half, underscoring both the scale of death and the deep disruption of future generations. Key impacts of colonization include population decline, loss of land and resources, cultural disruption, economic changes, and political marginalization. And although there were many laws enacted when colonizing the United States, I will mention what it is that is important to consider when discussing social determinants of health. The Indian Appropriations Act of 1851 was a significant piece of legislation enacted by the United States Congress that fundamentally reshaped the U.S. policy toward Native American tribes. This act marked a shift from earlier policies that have focused on negotiations and treaties with tribes to a more restrictive and administratively controlled approach. The Indian Appropriations Act of 1851 began the reservation era. The reservations confined tribes to small portions of their homelands through treaties, coercion, and force, while the U.S. claimed millions of acres of indigenous land. The creation of reservations through the Indian Appropriations Act of 1851 called for Indians' concentration, their domestication, and their incorporation. So using treaties, coercion, and military force, tribes were forcibly moved onto designated land bases. It was unlawful to leave the reservation. Treaties are legal binding agreements between the U.S. government and individual tribes that establish borders and conditions of the agreement. Reservations established during that era are areas of high distress. So mass displacement, as we understand it today, is a major feature of human insecurity and suffering, the underlying causes of which are conflicts over power, wealth, and resource sharing, and is considered a violation of human rights. It also isolates people from resources and networks that would allow them to reach their potential. And again, the conditions under which people are born, grow, live, work, and age affect a wide range of health, functioning, and quality of life outcomes and risks. And policies that create inequities across various levels, including organizations, communities, counties, states, and the nation, are key contributors to structural inequities. When we think about the results of this law, it was the act was a critical turning point in U.S. government policy regarding Native Americans, marking a shift toward a system that sought to control and assimilate populations into a society through U.S. society through reservation systems and federal oversight. The results of the Indian Appropriations Act of 1851 is extensive, particularly for those reservations established by treaty and have been maintained by the U.S. government for the past 170 years. In many cases, they are areas of concentrated poverty, and areas of concentrated poverty are linked to poor performing schools, increased morbidity and mortality, lower life expectancy, and social isolation. So early agreements established the federal trust responsibility, which obligates the U.S. government to protect Indian trust lands, protect tribal self-governance, and to provide basic social, medical, and educational services. So this is what the early treaties established for tribes. And so it wasn't until much later that we came to understand the effect of colonization. In a 1974 congressional hearing that describes the impact of such acts had on families, particularly children, and poor living conditions. And even though it was acknowledged as a problem in 1974, we've yet to establish a solution to the identified problem. So And this is so on the map on the right includes reservations. And the map on the left is of people living in poverty by county in 2010. The poverty map showcases high percentages of people living in poverty in areas adjacent to or containing reservations. Note that the national average for poverty contrasts starkly with the statistics for many reservation areas, indicating systemic inequality. By connecting these historical and contemporary elements, we can better understand the socioeconomic challenges faced by Native American communities today and the ongoing impact of past policies. So this is the map of the Indian Health Service 12 geographical areas. So the Indian Health Service is the government agency responsible for providing health care to eligible federally recognized tribes and is divided into 12 geographical areas. As we will see in a few slides, health outcomes depend on where one lives. So it is the 2 million Native Americans that receive care from Indian Health Service that experience the worst health outcomes of all major ethnic groups in the U.S. These percentages are of federally recognized tribes compared to the rest of the U.S. population. And as you can see, Native Americans experience significant health disparities. This is national data. When national data is disaggregated, we can see the impact of social determinants of health, and as you will see in the next few slides. This table displays the regional differences across the 12 Indian Health Service areas. The top two rows compare IHS national and U.S. data by life expectancy, poverty, education, income, and suicide rate. This is the difference between two groups, or the disparity. When national data is disaggregated, life expectancy at birth, poverty level, education attainment, income, and suicide all vary by geography. And to note here, funding allocation does not take this data into consideration. So communities receive the same amount of funding to address, for example, like suicide, whether they have a high or low suicide rate. Addressing social determinants of health is critical for improving overall population health, particularly for those that bear the burden of morbidity and mortality. Next, we'll look at life expectancy. So this is a closer look at life expectancy across the 12 IHS areas. If you were born or live in the Aberdeen area or Great Plains area, you can expect to live to 68 years. And if the Nashville area, 80 years. So again, significant difference depending on where you were born and live. And then we'll see the same thing with suicide, which I will show next. So this slide compares, again, the IHS national rate of suicide to the overall U.S. suicide in the top two rows. Again, when national suicide data is disaggregated, you can see a significant difference in the rate of suicide, further highlighting the impact of social determinants of health. Native American youth suicide is not about race. It is about the systems and environments that surrounds youth. And so we'll move on to talking about the high-risk reservation setting. So the Indian Appropriations Act of 1851 created a high-risk reservation setting. And just to highlight, this is one of the communities that we work with. We work with two communities. Both of them have experienced a suicide cluster. This is one of them. It was established in 1851 by the Fort Laramie Treaty. It is a reservation within a county listed among the 100 poorest and 10 least healthy in the United States. The tribal law enforcement of 18 police officers and 3 criminal investigators is 50% of what is needed to police this area and population. The violent crime rate in 2011 was 5 times higher than the rest of the state and 3 times higher than the U.S. rate. Nearly half of those living on the reservation live below the federal poverty level. And in 2010, after 6 suicides, again, this is their cluster, 6 suicides and 20 attempts in 5 months, tribal leadership declared a state of emergency. At that time, there were 2 behavioral health providers through Indian Health Services for a population of about 13,000 people. One position was vacant for 20 years. So, reimagining our future. Our collective contribution to improving health outcomes, improving outcomes for our people across a lifespan include Wakanyeza, or Little Holy One. It's an intergenerational intervention that is focused on both parents and children to improve outcomes over time. Young Medicine Movement, or the Pathway to Nursing Public Health and STEM for Ani and Nakota high school students, is designed to train high school students in nursing public health and STEM and prepare them for application to the NIH summer internship program, and as well as prepare them for higher education. In the morning, we present academic, they receive academic instruction, and then the afternoon is cultural immersion. So it's a mix of both. It's probably one of our more powerful interventions that we have. It also, we also have within that, embedded within that, something called the Futurity activity. And what it does is allow youth to create a future that they envision. And it's a very powerful part of the program. We have created a mental health certificate to train nurses and other providers that work in rural and remote Native communities as a way to address the mental health treatment gap. We have a Rise Up, or public health leadership training. We are in our 4th or going into our 5th year of training undergrad students in public health. This is through the Kennedy Krieger Institute. We are just finishing collecting data for developing post-vention interventions for those who have lost a loved one to suicide. And our upcoming projects are on data sovereignty, and then data management and evaluation, and then artificial intelligence and data science. Those are upcoming. This is our way of giving back to the community, but also contributing to making to improving outcomes for our people. So for these are the recommendations, or call to action. So targeted interventions aimed at reducing poverty within tribal communities. I think these are all, as I've gone through the work over time, over 10 years now. Our work should focus on reducing poverty. And we can all advocate for equitable treatment and equal access to resources for all tribal members. We can implement interventions across generations and conduct thorough assessments to identify the root causes of health disparities, enhance timely data collection and surveillance systems, and a focus on fairness across place. If we develop geographic solutions rather than focusing on groups or individuals, we might have more of an impact. The effect of colonization was and is profound, and we will not have the impact of a so here are some of the policy implications. One, uphold treaty obligations. I think these would have more of an impact on health outcomes, I think, than research, sorry. And then we need to understand how colonization affected the lives of Indigenous peoples to understand their health today. We don't have a full grasp of that. We don't learn it in school. Only by chance do we encounter it, and research or publications are hard to come by even. Reliable data are needed for the development of policy and health services. And we understood, particularly from COVID, the impact of not having data specific to our people. The exclusion faced by Native Americans is a major issue. Therefore, overcoming the lack of participation and consultation is critical for building responsive and coherent public policies. And correction of the present situation mandates a radical reorientation of previous strategies that have been ineffective or virtually non-existent. And over 10 years, let me see. So here are some of the most significant lessons we've learned over, well, I'm saying 10 years, it's 15 years of working with the Fort Peck Dakota and Nakota tribes and the Fort Blavatnik and Nakota tribes. Tribal leaders and community are the decision makers in tribal jurisdictions and control data and research. Institutional level change is necessary to reciprocal and trusting engagement. Participants or clients must be engaged to drive research engagement and direction at all stages, community members. Trust building and long-term commitment to community-defined needs. And then significant policy changes is mandated. In order to change like the youth suicide and suicide outcomes, policy change is mandated. So I'm gonna end here. I didn't realize I went through this so quickly, but so in conclusion, please remember that together as a community, we possess the strength to shape our own futures and uplift one another. Every small action contributes to a ripple effect of change, and united we can overcome the challenges we face. Let us continue to embrace our collective agency, foster resilience, and inspire one another, knowing that together we have the power to create a better tomorrow for our people. I just want to say that this understanding has taken me many years to get to this place, to truly understand the impact that social determinants of health have on our people. Well, thank you very much.
All right. Well, Professor Brocky, we're very grateful for your shared insights, the lessons learned, and an overview of so many of the elements that go into trying to work in Indian country to advance health and well-being, especially for our youth who, have some of the vulnerabilities based on many of the social determinants you discussed. So we've got some time for some exchange with the audience, and we will get to some audience questions. But, I wanted to ask you first, I think that some people would probably want to know in detail what some of your projects look like. If we're actually engaged with combating serious mental health issues in some of our communities, whether it's Fort Peck or Fort Belknap or other places, maybe you could share a little bit in terms of some of the details of how your projects unfold, how they're structured, what they found, and what you think the implications are.
Sure. I think, well, at Fort Peck, we did a study there, and we found that education engagement, communal mastery, and tribal identity were protected for high-risk substance use. And we also found that a family history of a mandatory boarding school experience was a risk factor for both suicide ideation and attempts. So when we developed our intergenerational intervention, we developed 4 cultural lessons. One was on enhancing tribal identity, one was on enhancing communal mastery, one was on healing historical and contemporary traumas, and the fourth one is on smudging for stress management. And so all of our projects are approved by tribal or authorized by tribal resolution, guided by a tribal advisory board. And so they really guide our direction. They help design those cultural lessons. We are just starting the analysis on that study at Fort Peck. Little Holy One is a 12-component intervention for parents and their children, 2 to 5-year-old children. And we have adapted 4 lessons from CETA, which is the Common Elements Treatment Approach, for mental health and substance use, and then 4 lessons from Family Spirit, which is a Indigenous parenting curriculum. We are just finishing that project at Fort Peck. In Fort Belknap, we did a mixed method study looking at suicide across multiple levels, and we did the qualitative arm of the study. We interviewed youth, service providers, and adults in the community. Both of the studies came right after the suicide cluster, so we're trying to get that information. As it relates to suicide clusters, we've also just collected information, data on developing, and this is from people who had lost a loved one to suicide. We just finished collecting that data, and we'll develop, again, postvention interventions for those who have lost a loved one to suicide in the community. And in Fort Belknap, we also developed Young Medicine Movement for rising juniors in high school. We're approaching our 5th year. Our first cohort are sophomores in college, and we have a group of them who have gone to the NIH Summer Internship Program or the NAU CARE Program for further research training once they graduate from our 2-year program. We just finished our mental health certificate program for training nurses and other providers that work in the community. And that really came as a result of having a conversation with public health nurses at Fort Belknap. And they were on the front line for addressing both COVID and the youth suicide cluster, because they happened at the same time. And what they said was that the needs of the community were around mental health, and they didn't have the adequate training. So we just are finishing with that and hope to launch that in the next year or so. I'm going to stop talking there, Joe.
Sure, and I want to invite you to unpack a few things because, we have a very eclectic audience today. Some of them are from Indian country and know a lot of what we're talking about by virtue of just referencing and describing or labeling what it is. But we also have members who don't know Indian country that carefully. And so You
Okay.
mentioned in description of the first project 4 different kinds of interventions that you thought would make a difference at Fort Peck, I believe it was, and that had to do with enhancing identity, enhancing mastery, healing, and smudging for anxiety or stress. And I wonder, some people don't know what smudging is, etc. So maybe you can tell us with each of those, what exactly do you do? Because even the folks in Indian country all want to know, what can we do? And those sound like a good set of strategies to try to make a difference. So, when you say enhanced identity, what do you mean? How do you do that?
So, with the guidance of our tribal advisory board, we come across they defined what it means. What are those strengths of a strong tribal identity? So for example, receiving an indigenous name or Nakota Dakota name is a strength of the community or a strength of individuals. And so part of that is part of the lesson is going through and helping people, parents and thus their children understand the importance of a name for their people. So that's one example for tribal identity, for communal mastery that really communal masteries like group efficacy. And so our lessons are really around strengthening family and community because what we found is those that are well connected and with a group, with a network, that is protected for, again, for a variety of factors. So strengthening family and community, and then for healing historical and contemporary traumas, talking through some of the storytelling around the traumas, and then some ceremonies around the healing. So we talk about wiping of the tear ceremony that helps people resolve kind of those past harms.
Great. And smudging for stress sounds like it could be really helpful, but not everyone will know what that means.
Yeah, so smudging is used really in preparation for ceremony, right? So whether it is a Sundance, and I'm from the Plains area, so that's my perspective. Whether it's a Sundance, a sweat lodge, or horse dance, or um, a spirit lodge, any of those, in order to participate in the ceremony, you have to everyone smudges, right? And it's a burning of plant medicines, and then it's you can say a prayer with the smudge. So anyway, it helps maintain balance and really clears the mind. Um,
Yeah, really, really essential to so many of our practices and something that anyone can do. So that sounds so promising. Um, a lot of the what you described about your projects is there's a community advisory board, and you're working with tribal leaders, and you're asking public health nurses what to do, and so on. And that's a kind of community engagement that often is not characteristic of research in mental health or in psychiatry and psychology and so on. And yet, obviously, it's something that's been very important for your work. So tell us about community engagement. Why is that so important? How do you do it? What would happen if you didn't do it?
Oh, see, I think community engagement is critical, right? Um, I'm not a researcher who just is interested in maybe I don't know where I will let me approach it a different way. So working with tribes is not a one and done thing, right? You have to engage, you have to make a commitment, a long-term commitment to working with tribes. And within the tribes that I work with, they have jurisdiction in those particular areas in their land. So respecting tribal sovereignty, we have to ask for their approval or their authorization to study this topic or not. They might say no. And then the other thing is, so we get a resolution for engaging, collaborating, and we get a resolution for each of the areas that we study. And then any grant proposal we write has a tribal resolution as well, because we don't want to be in competition with the community. So we want to make sure that we're not applying for the same grant as them. So our tribal advisory boards are defined by the topic that we're studying. So if it's in education, we want to get community members who have that background, education background. If it's in youth suicide, then we identify people who have worked in youth suicide prevention and intervention in the past and who can contribute to the project. They review all of our measures and often select the measures, and they review all aspects of our IRB, our consent forms and everything, IRB applications.
Wonderful, thank you. Early on, we had a question from someone just asking, about where the communities were, and of course, she later went on to talk about Fort Peck, Fort Belknap, which were in Montana. One of the things that struck me, of course, is that when you talked about the IHS regions and some of the inequities around lifespan, expected lifespan there, you pointed out that Aberdeen, which is, the Dakotas, and Billings, which is Montana and Wyoming, have, the lowest expected life, span in those areas. And which speaks to the part of the world that we're coming from, which is the Northern Plains. And so one, there's a diversity. There's some, like you said, Nashville is pretty high, but compared to, ours. But what is your understanding of how come the Northern Plains is just so vulnerable?
The way I understand it, for those reservations that were established during the reservation era, they were established under duress, right? They were forcibly removed onto these land bases, and then they were underfunded. They were not created to ensure that people thrive. They were created to control the people. And so they moved them on the reservation, and early reservation life was not good at all. Many people starved. It was an area of high violence. A lot of violence in those areas and far away from DC. So a lot occurred during that period. And so they've been underfunded from inception. So if we look at the number, so that's about 106 were established during that first era part. And then another, I can't remember, so maybe 30 over the next 20 years or so. So we have funding across those areas. I don't think that they have established a long-term strategy as to how people were going to live and make a living and how everything was going to be funded. So that is clear. It's for managing people. So over time, so we have those early reservation settings, and they've always been areas of poverty. And if we look at concentrated poverty, the rates of poverty in those areas, that's what drives health disparities. That's what drives social determinants of health. So at the same time, we have a limited amount of funding for these tribes. But then at the same time, what happens is the federal government creates a federal recognition process. So in 1950, there were about 250 tribes. Now we're 574. So the budget that provided has not increased at a level it should. So there are a couple of things that are going on: underfunded, and then adding more tribes to the same pool of money. There.
Yeah, right. Well, and you talked about the importance of, poverty. And so ways out of poverty seem like it could be really important for health and well-being, mental health. And yet you talked about the boarding schools briefly and how having, some of that history in your family can put you more at risk for problems today. And a lot of people have heard of the boarding schools in Indian country, but not everyone has. And, a lot of people, they hear boarding schools, they think Andover, Choate, elite prep schools that are, prepare you to tackle the world or what have you. Maybe say a little bit about the boarding schools and those experiences for some of our families and why there would be risk today stemming from those.
Yeah, so let me go back. I took it out. I did have some information on there, but I took it out. So um the Indian Appropriations Act was amended maybe 25 years later. And it established the boarding school system. And so children were forcibly removed from their families, their communities, and taken to boarding schools, often miles from their 2,000 miles. I'm going to say 2,000 because that's, I think, the distance from Fort Belknap to Carlisle. They were taken away from their families to assimilate them, educate them. Their hair was cut. They were punished for speaking their language, often abused. And so this set up, I mean, it has impacted our families for many years, has not been resolved. And so what we found as a kind of way to operationalize boarding school. So those early boarding school experiences were particularly devastating for families, for parents and their children. But now I'm losing my train of thought, Joe. So early early boarding school experience were devastating. So I have it back now. So how we operationalized boarding school was we defined it as a family history of a mandatory boarding school experience. And so we asked the participants if their great-great-grandparents were part of the mandatory boarding school experience. Again, that was where they removed the children from their families and communities. And then we asked them, for those who said yes, we asked them if it was talked about in their home, and for those who said yes, because we're trying to get at how we learn about these trauma experiences, and we learn about them through stories, not in school, in particular. So we asked them about whether it was talked about in their home, and then for those who said yes, we asked them then, was it a negative, positive, or kind of neutral experience? And more participants said it was a positive experience than a negative experience. I was surprised by that, but for those who said it was a negative experience, that was associated with both suicide ideation and suicide attempts. So
This is one of the things that we have to appreciate is the historical shifts in these things. And, we carry in my family, the Gone family, the signature of these boarding schools, because that's where Fred Gone got the name Gone, going to this boarding school when he was 5 years old in 1891. So yes, they've been really, really influential in important ways. You talked about the trauma, sometimes it carries through, and we have a question from a participant who identified as Stephanie Hernandez. Thank you so much for this important work, Dr. Brockie. I would like to know more about the intergenerational transmission of trauma that you've noticed in your research and groundwork with the communities. Can you explain more about how the intergenerational interventions address that? How do the communities feel afterwards?
well, we are just in the process again of analyzing that data. So we should have other results in the next few months. We'll have that published, the results of that study, intergenerational transmission of trauma. I think that's how we got to we were able to understand a little bit more about mandatory boarding school experiences through understanding at a level from the community in particular what some of those challenges were at the time. And I remember in when I was first started studying historical trauma or through as operationalized by boarding school. I remember going to one elder and he said that that was such a hard time for our people, and that parents, even though they didn't want their children to go, they sent them because if they stayed home with them, it meant starvation. So it was either one or the other. And so that was how we came to ask whether it was a positive or a negative experience, just because of that.
Yeah. Sorry about the tech issues here. Hopefully that's fixed up here. We had someone respond to your representation of IHS data and the federally recognized tribes, for example. And so this person wondered about the inequities faced by individuals from the state and unrecognized tribes who do not receive IHS services, which could exacerbate health-related inequities. What do we know, or how does that factor into your knowledge and research, the non-recognized or state-recognized tribal nations?
Yeah, I don't know if I've not seen any specific data on state recognized tribes, so I couldn't really speak to that. But I will say that in the recognition process, there are clear winners, and there are clear losers. So it appears that those tribes who are provided care strictly from IHS, solely from IHS, are the ones that are losing because there's less funding to support them. As again, the recognition process brings in more people to provide care for, either through BIA or Indian Health Service. So I think, I mean, I can't really answer that question. I just know that we need to have a study of it. We need to figure out like, because again, when I looked at that, I'm like, wow, that's incredible to go from 250 tribes in 1950 to now approaching 600 tribes. But I don't see that the budget has increased incredibly to account for those additional tribes and people. So again, there are clear winners, but there are clear losers, and I think we just need to do a good assessment and reporting of that federal recognition process.
Related to that, I suppose, Eric Coles writes in and says, does the data on IHS regions include the urban Indian population? And that's a whole nother area, of course, to think about how many of our tribal members aren't living on the reservation at any given time. What do we make of the urban Indian population?
Well, I have worked in a couple of urban settings before, and if we got IHS funding, we had to report. So I believe, and then there's a whole department in IHS. It wasn't back maybe 20 years ago, but there is a urban health department within IHS. So and I don't know if it is best to bring that number out, like from the geographical areas, and just report on urban members. I don't know if that's best, but the way that Indian Health Services Regional Differences report, it's like the most recent is 2012, I believe. It is slow slow production.
Um, that variation, that diversity is something that was significant for Thomas Hill, who wrote, "You've suggested shifting from individual group programs to region-based interventions. What makes region the right unit of change in Indigenous mental health? And how would you evaluate impact without erasing Native-specific differences?"
Hmm. Well, that's a good question. I'd have to really think about this and have a conversation with you. Um, but yeah, it seems like if we look at the way that we do things now is so we identify, for example, we use suicide. So we identify that suicide is an issue among Native youth. And so suicide has been the second leading cause of death for almost 40 years for our youth. And so what Congress says, because they're responsible, they pass legislation that would provide funding to address suicide. That funding is divided among these 12 geographical areas, and they really have to compete for the funding. So sometimes the funding doesn't go to a community that has a high rate of suicide. It'll goes to those who have the resources to write the grants. So that is one thing. But when we look at, I think, regions, that Upper Plains area, life expectancy, poverty. I I think for me, I just come to the conclusion that we need to figure out how to get resources where they need to go. And that takes a collective. We have to say, let's do this together. Let's figure out how we can get the resources there. Um, I think research regionally, I don't know. I would be interested in it. I would but yeah, I would have to think about this a little bit more.
Here we have someone writing in, "Thank you for your presentation, Dr. Brockie. I'm curious how your work might be addressing the applicability of the social determinants model for Indigenous communities and how you might be adapting the model to better suit Native communities."
Well, um, I I have not done work per se in social determinants of health. I wished that I had more time and more money because the area that I would focus in probably first would be poverty. Like, how can we address poverty in these really poverty-stricken areas? So I would do that.
Yeah. Here's from Vanessa Liang. "Hi, Dr. Brockie. I'm here with the Baker Center of Children and Families. Born and raised in Hawaii. I also saw the rise in substance use in Native Hawaiian youths. I also wanted to ask if you happen to also see any correlations of suicide of youths and being unhoused, and if it happened to find anything like that in your research."
Um, in Because of the shortage in housing, in reservation communities, there are multiple families living in homes. So they're not officially considered homeless, but they are, homeless. They don't have a home. So that's one thing. And in one of the communities, like, it is a really high number, like the number of youth who are not in their own families, living with their parents. We've not in particular looked at like homelessness, but we do have data on both quantitative data and qualitative data on overcrowding in housing. And then they call it couch surfing, right? The youth who are not with their parents, but they go from one home to the next and sleep on their sofa.
Here's a question from Nadia Dawood. Can you please expand upon data sovereignty, which appeared on your reimagining slide? What is data sovereignty and how do we think about that?
Well, I think that a lot of people are really talking about it, but I think it's always been there. We just came up with a term, right? It's, I think, couched within tribal sovereignty. And I think as tribes engaged in developing research plans, they also engaged in developing tribal IRBs, and then they became interested in their own data and the collection of that. And typically, what was happening before was that often researchers would come in, collect data, and take the data and not come back. I mean, often called a helicopter research. And they'd take tribal data, wouldn't benefit the tribe. And now I think tribes are expressing, it's an expression of tribal sovereignty that tribes say that this data is collected within our jurisdiction, it belongs to us. So in that way that they have control over it.
Yeah, and what are your thoughts about the fact that, for example, NIH might fund this research, which is taxpayer dollars going to, and the value of knowledge generated from these kinds of taxpayer-funded projects over against, tribal data sovereignty? I mean, do you feel like there's an obligation for this knowledge to be shared, and what if tribes say no, they don't want to do that?
Um, I think that's two different systems, right? The government and the tribes. I feel like um, tribal governance is protected by the Constitution, and it's based on treaties. And so I feel like, oh, it supersedes NIH, and Congress has a responsibility to protect tribes. However, the other thing is like the trust responsibility. It's really do all of the NIH institutes and centers are they responsible for the trust responsibility as well, and not just IHS because it's typically IHS who really works with tribes and lives up to that trust responsibility, which is, what they were created for. But do other institutes and centers also, should they also be living up to the trust responsibility?
Yeah, good questions.
Mhm.
Here's from an anonymous attendee. Can you share more about how you navigate building culturally grounded programs in a community like Fort Peck, Fort Belknap, where there is one reservation set aside for multiple different tribes with distinct cultures?
Um, well, what I learned right away is that when there are two separate tribes on a reservation, you have to be very careful. You have to make sure that when you're selecting your tribal advisory board, that you have members from both groups. You have to make sure that if you're being inclusive of both groups, otherwise they will call you out on it. And so doing that, and then what I learned when I did my first study it was at Fort Peck. When you engage tribes, when you engage the community and the people in the work, all of a sudden I realized that in the process of doing that first study, I realized that I was just like kind of helping along. They had totally engaged in the work and they were, doing what they could to make sure that it was successful. And I thought they really engaged and they became ownerships of the process. So that was very powerful to me. And then I saw the importance of, for me, that was the results of engaging with the community. And I always sort of kind of do it the same way. And as I go to it's usually tribal health or the health department to see what their needs are, to see what the issues are. But on the tribal advisory boards, we also always include spiritual leaders and people who have that knowledge in around culture and so we engaged them early on. I've learned so much by that process. It's a long process, I will say that, but I've learned so much, and it's really enriched our work, particularly when we're developing cultural lessons. It's not something that one individual, at least in my opinion, that one person can develop cultural lessons or content by themselves. It was a whole process. I mean, we used a iterative process with our tribal advisory board and our team here at Hopkins, and we just went back and forth multiple times, and then we piloted the lessons. We've adapted them numerous times now, but yep, that's the process.
You mentioned in your presentation about some of the work that you do around historical trauma in terms of conducting wiping of the tears kinds of ceremonies. Of course, Maria Yellowhorse Braveheart, who was a Lakota social work researcher, kind of invented a historical trauma intervention that featured this wiping of the tears ceremony, a couple decades ago now. And that intervention, you could think of it maybe as psychoeducational, and it's orienting and letting people, understand more about history and about their community. Related to that, I'd say Elizabeth Kane writes in and says, what are some effective ways that tribes are educating members on their rights when it comes to their own health and receiving treatment or checkups? Oftentimes, medical professionals treat our members with less care or trust than other patients, which makes it difficult. And so any advice for like how we could even be teaching our own people, to navigate healthcare when sometimes the providers aren't so sensitive?
Yeah, that's a huge task, I think. And there are a few things that we've done. And I'll talk about that and then talk about some of the challenges. But when we do the research, right, it's guided by the tribe, the tribal advisory board. You measure selection, approval, all of that's guided by the tribe. Once we get done with the study, then we do something called tribal data dissemination. That is, we return that data back to the community and not like hand it over in a Excel spreadsheet or anything like that. But we talk about the results of the study. We have the conversation about the study. And so that first study, then we looked at the risk and protective factors for youth suicide. We had a group of folks that the tribal chairman sent to our to these tribal data dissemination sessions, and then measure by measurable measure or concept by concept, we delivered the results of the study. We talked about what it looked like in other communities, and it talked about some of the solutions that could be enacted right there where they're working, whatever department they were working in. And I remember as we went through the data, there was one of the tribal spiritual leaders. He said, I knew that violence was a problem in our communities, but I didn't know to what extent. And he said, our kids are suffering. And from that day, he committed to do the work, to help the work. And so it's been 15 years now. He's still engaged in the work. And so that's one way of returning that information back to the community, because for those changes that need to occur at that level, it's the people who are working in those departments that really need that information. So that's one way. In Fort Belknap, we did the same thing. We went to got the study results. We went to the council first, tribal advisory board, tribal health, and then we went out into the communities and presented the results of the study. Now, bigger things, like we can do that, but we need more people in the know, right? So we've been thinking about what can So like public health campaigns, just to get the knowledge out there. We've been trying to work that through our Young Medicine Movement program, and let the youth design these public health campaigns. And so eventually I think that will I mean it has to do with applying for money, right? Because that's a big undertaking. So yeah, finding money to address those larger issues in across the community.
Well, getting the word out, as you say, is pretty important. And someone asked if you were to give advice to allies about how to collaborate to evaluate the outcomes of some of these youth programs so we get meeting results, what advice would you give? What is the role of allies in this work?
Oh, I would ask them to go look at that recommendations page, but allies, I think we need allies. First of all, I will say that there's too few of us Indigenous researchers to do the work that is required, that is needed to help our communities. So we really do need allies. I think working with other maybe Indigenous researchers or identifying someone in the community who's a strong advocate, and in co-designing, co-working, that sort of thing. But I've learned a lot through that process, and just because I'm native doesn't mean that things are the door is wide open for me. It hasn't been particularly at Fort Peck. That was a big learning for me. But through time, we've developed a really strong collaboration and work together. Yeah.
Right. I think that's, important to underscore for the research community in particular. Most people who do mental health research, and only a fraction of them do community engaged work, which of course is messier, slower, requires some additional relational commitments. But to do so in a way that's truly participatory with people and where there's a lot of skepticism and suspicion and mistrust from history of research in Indian country, it does make these partnerships something that takes a good deal of effort, goodwill, good faith to get off the ground. And I think a lot of the research world doesn't really fully recognize or appreciate how challenging that can be, for all of us engaged in Indigenous community work. We talked about education. You talked about the importance of kind of education a little bit. Early in your presentation on colonization, one participant writes in, you mentioned that education about this topic may not be as present in our schools and communities as it should be. What suggestions or recommendations do you have for schools in supporting the health and well-being of our youth as they learn about, colonization and various issues like that?
Well, I think the state of Montana did well when they passed that Indian education for all. So all students across the state, elementary all the way to high school, had to learn about tribes. And so I think that's a good start. It introduced the topic, the content into schools. And so more people could learn about it. But what happens is, I think we don't by far learn about true history of Native people and all that occurred. And so again, when we don't learn about it, when we're excluded from that, then people are able to make assumptions about who we are and what we stand for, and those assumptions are often really harmful. And so teaching our children, if they don't learn it in school, can we teach our children at home? And then can we work with our school officials, our school boards, to encourage inclusion of Indigenous content? I mean, yeah, because it's about inclusion and exclusion, right? Because if we're not teaching it, we're excluding.
Yeah. Rebecca Fineday writes in, amazing work and information, Dr. Brockie. Do you offer written or recorded resources for Native employees, nurses, and advocates working in non-Native healthcare entities to learn and utilize for Indigenous social determinants of health pertaining to Native patients?
Say that first part again?
Resources. They're just wondering about if you have any things to share or some way to help them better understand social determinants of health for Native peoples, because when they're working in non-Native settings, they don't get access to that necessarily.
Oh, I don't, well, I don't, I do have references. So Rebecca, I can share those with you. Um, we do have a couple of trainings that we're developing here in the School of Nursing currently. One is on a decolonizing nursing. The other is on cultural safety in nursing. And so what we did as part of one of our institutional challenge grants, we looked at our PhD program to see if there was Indigenous content in our PhD program. As it turns out, there was only one course that provided anything on Indigenous content. And so we decided that, okay, so well, maybe we'll support our faculty in being inclusive. And so we're developing these trainings again, for our faculty to help support them. So those trainings will be available to others outside the university once that's up and running. So I can share those with you too. But then I will back up a little bit into that term, cultural safety. That term was first coined in New Zealand many years ago by Maori nurses. Now, in the whole country, all nurses have to take that training, cultural safety training. In Australia, all nurses have to take cultural safety training. And so that term is just kind of getting to the states a little bit more published on and discussed in Canada, but we're always late, so we're late to
Right.
understanding, right?
No, of course, you talked about the young medicine movement and the work you do to try to bring young people into awareness and recognition of healthcare and health concerns and, prepare them to maybe go on into those fields. So, Kathleen Harazea writes, are there vocational interests of youth that you would suggest we try to address? Vocational interests that you're hearing from them?
I think there are. I don't know. I don't know in particular what they might be, but I think there are like yeah, through the tribal college, I know that there's interest in vocational training. So there are opportunities there for that type of training. Our training, our young medicine movement training is on career planning. We present content on biology, chemistry, neuroscience, public health, nursing, and then mental health, which we call building resilience, and then planning for your future. And we bring in high-level instructors or faculty to teach these courses, the content. And this is an opportunity that they would not have. They would not have access to that in their community. And so again, we currently don't have a contract. We're hoping for this year though. We're hoping for our fifth year. So next month we'll know whether we have a contract or not. But it has been very powerful to see the change in youth from the beginning to the end of 7 weeks. Just through the process of not only academic preparation, but also cultural immersion.
And that's such an inspiring program and important work, and it's at home. And so I really hope that gets funded because that needs to continue on.
Yeah,
Well, yeah.
Joe, I will say back to you that they want to see more of you.
Oh,
So we have to find an opportunity for them to see more of you.
okay. Good to know. We'll figure it out. Just to close then on one last question, and it's a pretty big, broad question, but it's something we should all probably be thinking about, which, someone just simply asks, what does progress in this domain look like to you?
Well, when I started the work, I thought, well, I'm going to make a commitment to try to make a difference for Native youth in particular. Um, and I thought, okay, I'm going to do what I can, and if I can move the needle, move whatever an inch, then I would have done some work. And now, like after, I don't know, 15 years of doing this work or so, really engaged in it, I think that we could make more immediate and more change and progress with one policy change. Really, I mean, I feels like, wow, I'm spending all this money on research. I'm like, if they could just enact a policy and change some things, that would really have an impact. So I feel like, again, I'm committed. I'm not doing this work, but I often feel like, oh, should I just, step away from intervention, develop and focus on policy or try to figure that out? I'm not sure, but I haven't quite figured that out yet. So I'll just keep pushing forward.
Well, for our last comment, it's just a comment instead of a question, but it's from Amanda G, who wrote, "Thank you so much for all your work. I'm so grateful to have this seminar to learn from. I work for the American Indians in Texas at the Spanish colonial missions here in Yanaguana, Texas, or San Antonio. This hits home for the work we do. So again, thank you so much for all that you do." And it's important to recognize that. I think that this particular webinar series that we do goes out to Indian country, and people are able to participate from anywhere in the country and sometimes Canada or wherever. And I think people do really appreciate the opportunity to hear from you, an expert who's done this kind of important work, committed and dedicated in the ways you've been. It's all so inspiring, and you've got great lessons to share with us. And so I've been really grateful to have a chance to talk with you today, to hear from you today, to learn from you today. And I'm so grateful that you agreed to join us. So thank you so much, Dr. Brocky.
Thank you, Joe, and thank you for the opportunity. I'll be excited to see you, and hopefully on Fort Belknap. I'll be able to see you next, and I'll let the youth know that you heard the message, and thank you very much again, Joe.
Very good. Okay, folks, our next Indigenous Health and Wellbeing Colloquium is scheduled for April 8th. So mark your calendars. For the next one, we'll feature a team of researchers this time, including Doctors Elizabeth D'Amico, Dan Dickerson, and Carrie Johnson. We'll talk about us from some of their work in California. So please be on the lookout for an announcement closer to those dates. And I want to thank my colleagues and staff at the Harvard University Native American Program, HUNAP, including Ollie Rincon and Erica Green, who you've seen in the background here. But without them, I would not be able to do this very effectively at all. So we're really grateful to the HUNAP staff. And of course, to my colleagues and friends in the Department of Global Health and Social Medicine at Harvard Medical School for your ongoing support of this seminar as well. Thank you, everyone. And we look forward to seeing you on April 8th. So long. Bye-bye.